Good morning, and thank you, APU and AIOS, for a wonderful conference and very good interactive between all the colleagues we have here in the Asia Pacific region and abroad. And today I'm going to present here on retinal detachment session, a management of detachment in high myopic eyes. So I do not have any financial disclosure. So as we know that in myop patient, there's a constant elongation of the axial length, and that leads to structural changes in the posterior segment, and there's a loss of best corrected visual acuities. So high myopia is who has a -5 or -6 diopter, whereas a patient who has a posterior staphyloma or any maculopathy, then that leads to a posterior pathological myopia. And as we know that the patient of myops are increasing in our part of the world, in Asia Pacific regions, and the number of myops, which compared to 2000 and now next 2050, the number of high myops will be double. So currently we last consensus said that it was 400 million of high myops. So now the number will be more than 900 million myops in the entire world. So the number is more in our Asian populations, and in Asian also the visual impairment is almost up to 1.5%. And in the Eastern Asian regions, Japan they have a third leading cause of bilateral blindness, whereas in China the leading cause of blindness in the young age groups are because of high myopia and pathological myopia. So the main pathogenesis is basically the choroidal thickening. There is a progressive thinning of the choroids, and that will cause atrophy on the posterior pole with atrophy of the Brock's membrane as well as the atrophy of the RPE. So there's a presence of this atrophy as well as there's posterior staphyloma and a lot of activities that happens in the posterior pole that leads to impaired vision and even losing the base corrected visual acuity. And those are the patchy atrophy and myopic, the macular neovascularization that leads to a permanent loss of vision. And the detachment happens when there's a peripheral retinal tears or peripheral retinal holes. And this is one of my patients whom I was seeing for last 10, 15 years, a young girl who came to college, after seeing from her till when she was grade 4 or 5. And she landed with one annual checkup, the holes in her peripheral retina and right eye, and did a retinal laser. So patient with high mass may land up with a giant retinal tear in such a scenario when we have to do immediate interventions. So as we know that the phakic arteries below 50 years are because of high myops, as well as in the post-cataract surgical patient whom we do retinal detachment surgery, those patients who are high myops, there are more chances 10 times more chances to have a retinal detachment. So what are the risks of, the challenges of doing surgery in retinal detachment in high myops? So one of the most important is the thin sclera. The patient who has a high myops has a long axial length, so instrumentation may be difficult for reaching the posterior pole. And there's a degenerative and unsuccessful PVD, especially most of the patients are younger without PVD. And there's a thinner retina, and one of the very, very important is multiple retinal breaks. So there might be holes in the lattice, which may open while doing surgery, and the peripheral retina, we might miss the holes in the peripheral retina. So these are only intraoperative, but as well as in the postoperative, the patient may land up with a PVR complications, as a previous colleague has mentioned about the management of PVR and postoperatively also. There's one of the very important is hypotony, but secondary glaucoma. I'm sure many of our colleagues have faced complication of postoperative glaucoma management is very difficult. And this is a case who had a fairly good visual acuity, but landed with a high myopia, but retinal detachment with multiple tears and holes. So this was one of a patient who is 64 years, fairly cataract of nucleus 1, and he landed with a detachment. And there was a very big retinal tear, not a giant, but a 2 clock hour retinal tears, as well as more than 5 retinal holes. And the holes in the lattice did open while doing surgery. So it's very careful, like the retina is very thin, so we should be manipulating very minimal manipulation in the peripheral vitrectomy when we do indentational vitrectomy. And we have to identify all all the holes that we might miss. So we need to address all the peripheral retinal holes, which might probably we have to be rescheduling the whole 360-degree repeat examination of the peripheral retina. So this gentleman had a silicone oil injections and had a fairly good visual acuity, maintained intraocular pressures, and we did. After 3 months, we did a cataract surgery combined with silicone oil removal. So this is a case where I usually use silicone oil when there is a multiple retinal tears or a complicated retinal detachment. And here I did a very good cataract surgeries and implanted the intraocular lens on the same settings, and did a fluid directions and checked the peripheral retina to see if there's any PVR, if there's anything that we have to do redo anything inside the eyes. And this is the one case. She's very young, and she's just 18 years old, and she is high myopes, -7 diopter, and she had an intertemporal retinal detachment due to the holes in the lattice. And I did a segmental silicone oil 276 tire. And this is a case where it's a very easy surgery, 20 minutes for us. And we do a lot of buckles also in Nepal. And here with a single intervention of segmental buckle with cryo, and then I added on with the laser, and the fluid was there for a month, but it dissolved after 1.5 months, and see fairly, there was no any changes in the refractive error or in the postoperative, the C was comparatively, relatively very good. This is a case where now the posterior pole, there might be a macular detachment as well. There's an anteroposterior tractions, tangential traction, and posterior cephalamids. So those are the posteriorly, when there is a macular hole, the detachment we might face with the macular hole detachment, which might be involving only macula, or it might be involved in entire retina as well. So these are I'm not going in detail, but the main pathogenesis for posterior pole macular hole in the high myopes is vitreomacular traction pathology, foveal schisis, and chororetinal atrophies. And I'm sure there's been many comparative studies that has done comparing the ILM peeling or not. But one of the best treatment is to do a surgery, and we use a heavy liquid and ILM peeling on the same settings, and it's one of the very good options for retinal detachment, macular hole retinal detachment, where we can peel and use a heavy liquid for addressing the macular apposure. So this is one of the study from the UK where PFO has been shown that the study mentioned that the outcome is comparatively fairly good, and 100% macular hole closure using the PFCL. And this was a study from UK, and they mentioned that the plasma vitrectomy for macular hole in RD, retinal detachment, almost the closure was 25%, and reattachment was almost 80%. So to the conclusion, myopia is escalating in pandemic in Asia-Pacific region, in the Eastern Asian countries, and complication of pathological myopia leads to unilateral and bilateral vision loss in young patients. And the risk of retinal detachment in phakic eyes and myopes is increasing with the age, and there's a choice of different surgical techniques from buccal to vitrectomy. So the visual outcome depends on the extent of chororetinal atrophy, presence of staphylomas, and status of fellow eye. So I'd like to thank all the organizing committee and scientific committee of AIOS. Thank you so much.
Thank you, Sanyam. One of the things which probably need to be emphasized, and we always talk, and maybe you could have shown that more, the challenge is the removal of posterior hyaloid. And the maximum failure rates which are seen in high myopes are because of that.
Yes, sir.
Even sometimes we have removed once, it is still there, you go back and put again triamcinolone and try removing it, and you would succeed.
Yes,
I think that is one thing which has to be kept always in mind. And if we don't do that, whatever we may do, that detachment is going to come back. So that is what I just
Yes,
wanted
sir.
to
Thank you,
addition.
sir. Yes.